Hey guys, I hope you all are enjoying your break off. My conference is going fine, a little long, but can't complain too much. So today we'll be talking about chapter 21, which is dealing with infectious diseases that affect the respiratory system. So continuing on our infectious disease kind of block of talks. So let's go ahead and get started. So a little bit about the respiratory system. It's essentially any organ associated with either bringing air into the body or releasing carbon dioxide gas as a waste. So this includes the sinus cavities, the nostrils, the mouth itself, the throat, the esophagus, then into the bronchus, and then into the lungs themselves. So anything that deals with bringing oxygenated air in or carbon dioxide out. Primarily it's broken up into the upper respiratory tract, which essentially is everything up here, and then the lower respiratory tract, which is everything down here. Generally speaking, the upper respiratory tract has plenty of commensals. It's basically full of bacteria, and then the lower respiratory tract should be pretty much sterile. So because the respiratory tract is constantly taking in oxygen, constantly releasing carbon dioxide because we're breathing on a very regular basis, it is constantly bombarded with tons and tons and tons of potential pathogens. So for that reason, most infectious diseases gain entrance into the body via the respiratory tract. So you'll see here what we talked about before. The upper respiratory tract is primarily the mouth, nose, nasal cavity, sinuses, pharynx, epiglottis, and larynx. And then the lower respiratory tract is the trachea, bronchi, bronchioles, lungs, and alveoli. So some respiratory defenses, a lot of primary defenses just to kind of block any potential pathogen from making its way into the lungs before it can actually get there. It saves a lot of energy by having a bunch of primary defenses. So nasal hair, cilia, mucus. Cilia primarily move up in opposite direction of the airflow going into the esophagus, and this kind of pushes any organism out. Also, there's plenty of mucus. Mucus catches organisms, acts as kind of like a sticky little trap, and then the cilia will push the mucus out further so you can then swallow it, digest it, or cough it up. There's also a lot of involuntary responses, so coughing, sneezing, and swallowing, all of which are there to kind of push any potential pathogen out of the body or swallow it into the digestive tract, which then it gets broken down by proteolytic enzymes or high pH in the stomach. Macrophages, there's tons and tons and tons and tons of macrophages in the lung. Each alveoli has its own resident macrophage called a dust cell, which basically phagocytoses any foreign material, including dust. Secretory IgA, so since there's a lot of mucus here, you would expect that there'd be a lot of IgA as well, since IgA is excreted from the mucous membranes. And then normal flora, which you find primarily in the upper respiratory tract, acts as a great community organism to kind of prevent excess nutrients being available for potential pathogens. So normal biota of the respiratory tract, so it's generally limited to the upper respiratory tract. However, you will occasionally find things in the lower respiratory tract, and that's not completely unheard of, and generally most people are healthy even though there's some transient microbes in that region. Most of the organisms are gram-positive, so streptococci and staphylococci, both of which can be pathogenic if they migrate or are transferred to a different portion of the body, especially in the upper sinus cavities or if you get them on your skin. Disease-causing bacteria are present as normal biota, but you generally don't get disease from these unless you become immunocompromised or if you transfer your commensals to an unsuspecting individual who has never come into contact with that organism before, and it then can become pathogenic that way for them. So that's just a little synopsis slide of what we just talked about. So let's start off with the upper respiratory tract diseases. So first off, we have rhinitis, or the common cold. It's caused by rhinoviruses. Most people, I mean, I'm pretty sure there isn't a person around who's never not had a cold. Basic symptoms are just sneezing, scratchy throat, runny nose, rhinorrhea, which is just constant dripping in the nose. Symptoms begin 2 to 3 days after infection. Generally not, you don't have a fever. This is what kind of distinguishes it from the flu. However, you could have potentially have a low-grade fever associated with the common cold. So there are 200 different viruses that cause it with 99 different serotypes. So this basically gives you an unlimited variety or amounts of different viruses that can cause the cold. For this reason, there is no cure for the common cold because every cold infection is generally a different virus, different serotype, making it very hard for us to produce a viable vaccine against it. Transmission is primarily through respiratory droplets or contact with infectious saliva, and other virus types are coronaviruses and adenoviruses. Almost always self-limiting, never life-threatening unless you're severely old or immunocompromised. Sinusitis, so commonly called a sinus infection. Generally this comes after you have a cold, and that's because during a cold you have kind of a buildup of mucus, especially in the sinus cavities, and this acts as kind of a nice little breeding ground for certain strains of bacteria. And often it's bacteria associated with normal commensals found in the sinus cavity. But under normal conditions, there's not enough mucus for them to survive in until you get something like a cold that causes inflammation and buildup of fluids. Symptoms are nasal congestion, pressure above the nose or in the forehead, and feeling of headache or toothache. So generally anywhere you have a sinus cavity, it can then become inflamed. Once it's inflamed, pressure builds up, primarily from mucus and edema or fluid buildup, and this pressure can cause a lot of pain depending on where it's located. Facial swelling and tenderness can also be common. Discharge appears opaque with a green or yellow color in case of bacterial infection. If it's a clear color, it's probably viral in origin. This is pretty much true with all of these diseases we'll talk about. If you get a green or yellow discharge, especially in your mucus, it's probably bacteria. And if it's a clear, kind of liquidy, runny kind of discharge, it's probably viral in origin. And discharge caused by allergy is clear and may be accompanied by itchy, watery eyes. Fungal sinus infections are rare. However, they're becoming more common, and fungal sinus infections are impossible to treat. The only way to get rid of a fungal sinus infection is by surgically going into the sinus cavity and removing something called a fungal ball, which is essentially fungal organisms packed up in like a nice little mucus ball that is almost impossible to treat with current drug therapies. Sinusitis too can come in a couple different flavors. There's acute and chronic. Acute is exactly like it sounds. It only lasts for a couple weeks. Generally you get it after a cold, but then it goes away. Chronic is where you are constantly plagued with the sinusitis. And this generally happens to people who have chronic allergy or allergic responses because they're constantly having this inflammation in their sinus cavities, which is blocking the fluid from draining and resulting in bacterial growth. Otitis media, also called an ear infection. So this generally happens after some sort of respiratory infection as well, and it's primarily because the eustachian tube, which is the primary drain tube of the ear, it allows any built-up fluid behind the eardrum to kind of drain into the back of the throat, and then it can follow or drain down into the digestive tract. But after a respiratory infection, the eustachian tube tends to get inflamed, and once it's inflamed, this fluid has nowhere to go, and this turns out to be a perfect breeding ground for Streptococcus pneumonia or Haemophilus influenza. So once these guys start to grow in here, then you get an immune response, which increases the inflammation in the eustachian tube, preventing less fluid from draining out. And that's when you get this excruciating earache followed by a fever. So it's a common sequelae of rhinitis. Viral infections of the upper respiratory tract lead to inflammation in the eustachian tube and buildup of fluid in the ear, and can lead to bacterial multiplication in the fluids. Chronic otis media, when fluid remains in the middle of the ear for indefinite periods of time. And this is usually caused by biofilm bacteria that doesn't dislodge from the eustachian tube and behind the eardrum. Generally, you see this in younger children, and it can also be caused by a birth defect in the eustachian tubes that no longer drain properly. Symptoms, so sensations of fullness or pain in the ear, loss of hearing, along with generally a pretty low grade but still substantial fever, and general yuckiness. You tend to get pretty achy when you have an ear infection. Untreated or severe infections can lead to eardrum rupture, and that's because the pressure builds up to such a high capacity here that it pushes out on the eardrum and causes it to rupture. So pharyngitis. So pharyngitis is a very, very common upper respiratory infection, and essentially what it means is inflammation of the pharynx and or the throat. And it's retted mucosa, swollen tonsils, sometimes white packets of inflammatory products on the tonsils themselves, which you can see here. By far the most common of these, at least bacterial-wise, is strep throat, caused by Streptococcus Pyogenes. Likes to infect the tonsils. The tonsils are essentially modified lymph node organs, which are primarily there to kind of catch any potential pathogens before they make their way into the lower respiratory tract. So there's a lot of immune cells in this region, a lot of cells there to kind of phagocytose, cause an immune response, and so forth. So that's why they tend to get very large and inflamed during this infection. Often results in foul-smelling breath, and that's because the bacteria are producing a lot of stinky stuff, just like they do in lab. And incubation period is anywhere from 2 to 5 days. So like I mentioned, the primary causative organism for this, at least for bacterial pharyngitis, is Streptococcus Pyogenes. So in America we call this strep throat. It's a Lancefield group A strep, which is a test we haven't done in the lab, but it primarily uses antibodies to identify the organism. It's beta hemolytic, which you can see here. So you can see it's kind of cleared out the red blood cells in the plate or in the auger, and it's bacitracin and susceptible. You can identify it by doing throat cultures, which is kind of the old school method. It works well, but the biggest problem with doing a throat culture is it takes 16 hours to incubate before you get a result. Newest way is by using a latex agglutination test, which you can see down here. You just mix a little bit of the culture swab from the tonsils with these latex beads, and if you get agglutination, which are these kind of little, dots of beads sticking together, then you have a positive result. You can get this within a couple minutes. And beta-lactam antibiotics are the most successful at removing the organism, so penicillins, moxicillins, and so forth. So Streptococcus pyogenes, when it causes strep throat, is generally a fairly mild infection, so fever, sore throat, large tonsils, achiness, but as long as you get it treated with the beta-lactam antibiotics, you should be fine. However, if you don't get it treated and the infection prolongs and goes on for a long period of time, you can run into some more severe complications. The first one being scarlet fever, which is the release of a systemic toxin, usually a hemolysin, which lyses red blood cells, and this toxin distributes throughout the body and causes a red rash and a more severe fever. Generally, it's not too serious. It's kind of like a warning sign to say, hey, go to the doctor and get additional treatment, get some more antibiotics. But if you let this go for a long period of time, then you can fall into rheumatic fever territory, which is where the organism actually disseminates. So it leaves the tonsils and migrates throughout the body, also producing more exotoxins, causing joint inflammation, which causes like arthritic joints, primarily in the knees and the elbows, and then heart valve damage, where the Streptococcus pyogenes actually attaches to the heart, creates a biofilm, and produces toxins that results in damage. And then if you let this go untreated for a prolonged period of time, you can further get glomerulonephritis, which is essentially breakdown of the nephrites in the kidney. This is primarily due to all of the red blood cells being lysed. They get trapped into this filter mechanism in the kidney, and results in kidney damage and possibly death. So the moral of the story is if you have strep throat, make sure you go to the doctor even if you think it may not be strep throat, just to be on the safe side, or be caused by the bacterial organism. And antibiotics are key in preventing these things. But the good news is the Streptococcus pyogenes is very well treated with antibiotics. There's very little resistance to current antibiotic treatments. So some virulence factors of Streptococcus pyogenes. So surface antigens, toxins, and enzymes. Just like other strep organisms, they produce a lot of toxins. There's a erythrogenic toxin and a streptolysins, both of which result in hemolysis or lysing of red blood cells. Polysaccharides that prevent digestion, making them pretty resistant to a lot of enzymatic digestive processes our body produces. Spiky M proteins prevent phagocytosis, so stopping the macrophages and dendritic cells from engulfing the organism. Capsule provides adherence, so it makes them really sticky, allows them to stick to the tonsils very well. And they also can produce superantigens, which we talked about earlier, which are essentially antigens that are released from the organism that kind of overstimulate the immune system, resulting in a cytokine storm and eventually shock. Also, it's important to know with Streptococcus pyogenes, there are people who are chronic carriers, so they carry the organism in their tonsils for prolonged periods of time, either getting sick every now and then or not getting sick at all with strep throat, but they do have the potential of passing it on to an unsuspecting victim. The people who get sick only every now and then with strep throat, maybe every year for example, are probably chronic carriers that have very low amounts of the organism. Then as that builds up, they become sick. Then the immune system reduces that large amount to a small amount of organism again, starting the cycle over. Alright, so diphtheria. So it's caused by Corynebacterium diphtheriae. It's a gram-positive bacillus. This is a toxigenic disease. So the organism itself does not cause the disease. It's actually the toxin it produces, which is the diphtheria toxin. It produces a toxin thanks to a lysogenic beta phage, which is a bacteria phage that injects bacterial DNA instead of viral DNA. And this bacterial DNA codes for the diphtheria toxin. And it generally produces a pseudomembrane. So this is one of its telltale symptoms. The pseudomembrane is kind of just a thick kind of flotilla or like raft of bacteria and mucus on the back of the throat, which you can see here. So symptoms initially experienced are in the upper respiratory tract. So it's generally just a sore throat. You get the pseudomembrane formation and lack of appetite, low-grade fever. Biggest problem with this is you'll get really huge swollen and large lymph nodes to the point where it can actually block airflow and result in suffocation. And if you have the illness long enough and don't get it treated, the diphtheria toxin can build up and it actually can migrate into the heart and cause myocarditis, which is basically a breakdown of the exterior lining of the heart. Good news is that we don't really see this too often in the United States because there is a great vaccine, the Tdap vaccine, which is tetanus, diphtheria, and pertussis vaccine, which works extremely well. I think in the article I just read a little while ago, there have only been 3 cases of diphtheria in the United States in the past 6 or 7 years. So it works pretty well, and so we don't really see this too often, which is good. But the diphtheria toxin is an AB toxin, so we've talked about these before. B allows it to be endocytosed into the cell, where A acts as the fundamental cytolytic unit that causes cell death or toxicity. So now we'll talk about diseases caused by microorganisms affecting the upper and lower respiratory tract. So generally they start up in the upper respiratory tract, then after a prolonged infection there they will migrate down into the lower respiratory tract. So a number of infectious agents affect both the upper and lower respiratory tract regions, and most are well known. Most well known are whooping cough, respiratory syncytial virus, and influenza. So whooping cough is caused by Bordetella pertussis. Pathogenesis is localized infection, toxin production, and then damaged cilia. So essentially what happens is the organism makes its way into the upper respiratory tract, primarily the back of the throat and the esophagus. Here it kind of sets up shop, starts producing a toxin, and this toxin basically kills the cilia in the esophagus. So what ends up happening is you reduce the ability to move mucus through the esophagus, because that's primarily what the cilia do, is they take the mucus from the bottom and push them up to the top so you can then cough it out and swallow it. But after the cilia have been paralyzed or exterminated or killed, it becomes very hard to remove this mucus, so you get a constant deep cough trying to remove the mucus as much as possible. But really, it's a really ineffective cough, because without the cilia, you just physically can't get the mucus through the esophagus just by coughing. But the good news is the Tdap vaccine, the P stands for pertussis, so it actually prevents this infection, so we don't see it very often in the United States. But you will still see it in a lot of third world countries. All right. All right. And then, so the stages of whooping cough, you start off with the cartherial stage. So this is after incubation of about 3 to 21 days, and bacteria in the respiratory tract cause what to appear cold symptoms. So you get cold, runny nose, headache, general malaise, but nothing too serious, pretty nondescript. And this lasts for about 1 to 2 weeks. So this is where the bacteria is getting in and setting up shop. So just starting to grow, starting to become pathogenic. Then you go into the perioxysmal stage, and this is severe uncontrollable coughing. And the biggest problem with this is the severe uncontrollable coughing can last for months on end, because basically what the toxin has done is killed the cilia. So now your body needs to either reproduce the cilia before they can start working again. So until this happens, you're constantly coughing. And the coughing is so severe that you can result in burst blood vessels, watery eyes, and even vomiting. So it's pretty annoying, to say the least. And at this point, the toxin's already done the damage. So you can take antibiotics, you can get rid of the organism to prevent more toxin production. But since the toxin has already killed the cilia, you're still going to have the cough. It will not go away. Then you are followed by a long recovery convalescence phase. So complete recovery takes weeks or even months. And other microorganisms can more easily cause secondary infection. And again, this is due to not the lack of cilia and the lack of the ability to move the mucus, which have caught other organisms out of the body. Respiratory syncytial virus, or RSV. So this produces giant multinucleated cells, or synesthesia. So synesthesia is where you have cells that have fused together because of an infection. So it's most prevalent in newborns. So almost 90% of newborns will get this infection. First symptoms are fever that lasts approximately 3 days, rhinitis, pharyngitis, and otitis. And then more serious infections give rise to symptoms of croup. So coughing, wheezing, dyspnea, and rales. Dyspnea is shortness of breath. And rales is kind of a crackly sound inside of the lungs. So most causes of croup are actually caused by Haemophilus pneumoniae. However, a significant portion of them are actually caused by respiratory syncytial virus in young children. Alright, so now onto the flu, or influenza. So it begins in the upper respiratory tract. Serious cases may also affect the lower respiratory tract. So generally it's an upper respiratory tract infection, but if you have a prolonged infection, or if you're severely immunocompromised or extremely young or extremely old, then you can run into a lower respiratory tract infection. And these are the ones that are more serious and often can be deadly. It has a 1 to 4 day incubation period, and symptoms begin very quickly. So it's a headache, chills, dry cough, body ache, fever, stuffy nose, and sore throat. So again, these are symptoms we've all come into contact with before. We've all had the flu. It's very similar to having a cold, except you're a little bit more achy, lasts a little longer, and you generally have a fever. And extreme fatigue can last a few days or a few weeks, and it's actually a big hamper on our economy. We lose billions of dollars a year because of influenza by preventing people from going to work and completing their jobs. So influenza, this is what it looks like. So the most unique thing about influenza is that it has a segmented RNA genome. It is a zoonosis, so it is a virus that originated in birds, but it has migrated into humans and pigs primarily, but other animals can also be affected. There are three viruses, A, B, and C. A being it used to be the most severe, not so much anymore. B being a little bit more severe, at least in humans. Birds are common reservoirs, and that's because they are the primary target for the infection. And it's an enveloped segmented RNA virus, and it has unique spikes on the outside, and these spikes are actually enzymes. The first one being hemagglutinin, which binds to sialic acid on cells, and this allows the cell to enter, or first pick the cell of choice. The only cells that produce sialic acid will be bound to, and then it also allows the cell to, or the virus to enter into the cell. And the neuraminidase, or NA, neuraminidase basically acts as a viral release mechanism. So after new virions have been produced, so after a cell's been infected, it's gone through the viral life cycle, and then they produce new viruses. The virus buds off of the cell, but then it's kind of stuck there by a little tether, and it uses neuraminidase to break this little tether so the virus can be released and infect another cell. And influenza has this uncanny ability of mutating certain regions of hemagglutinin. So for our body to produce an appropriate immune response with memory, we need antibody production, and antibodies can only be produced to exterior proteins. So common targets are hemagglutinin and neuraminidase. However, the virus itself tends to mutate regions of hemagglutinin and neuraminidase that are not required for its function, but are often the ones most exposed to the immune system. And by mutating these, it prevents the immune system from producing an antibody that works all the time. And the antibody loses its effectiveness as time goes on. And this is primarily caused by a process called antigenic drift. So these are just general mutations of genes. So by slowly mutating a couple nucleotides here and there, it alters binding sites, especially for antibodies, but it's a pretty slow process. And the vast majority of antigenic drift actually results in abortive virus, so virus that no longer functions. But because so much influenza is being produced, occasionally some of these mutations are going to be beneficial. And these beneficial ones survive longer because of natural selection and then can be transferred to another unsuspecting individual. But influenza has another unique property called antigenic shift. And antigenic shift basically is gene reassortment. So it's basically because influenza has this segmented genome, what can end up happening is say I'm a person, I come into contact with influenza from one person, and then I come up into contact with a different form of influenza from another person. So I've become infected with two different versions of influenza, like in this example here. So these two different versions of influenza have two slightly different segmented genomes. Now what can happen is in my cells, one cell could potentially get infected with both versions of influenza. And when this happens, what ends up happening is some of the segments from the first virus will mix with some of the segments from the second virus. So what you end up with is a hybrid virus, which has, maybe in this case it looks like it has 7 segments from the pink virus and 1 segment from the blue virus. So now I have a pretty unique virus compared to the first two. So it's kind of like viral sex. You're taking some from one virus or one version of the virus and some nucleic acid from another version of the virus and mixing it together to make a new virus that has pretty different characteristics about it. And this is a very rapid process. All it requires is you becoming infected with 2 different versions of influenza, and this happens more often than you would think. So the subtype range, this is generally what happens because of antigenic shift. So this is where you, what ends up happening is you get infected with 2 different versions of influenza. Genetic material gets mixed up in the new virions that are produced from that infection, and you come up with different flavors of influenza. And these flavors of influenza allow for the virus to infect different animals. And that's why you often hear things like pig flu or swine flu, because they originated in those animals. They're primarily infected in those animals, but they have been able to kind of change themselves just enough to where they can infect humans as well. And these are often the more scary versions of influenza because they can be totally different versions of influenza we've never seen before, which make them harder to treat. Excuse me. And they can be versions of influenza that our body has absolutely never come into contact with before. So there's no immune response whatsoever. And if they're virulent enough and work fast enough, it can result in a pretty quick death. So hemagglutinin, again, is used for viral entry. There are about 16 different variants. Of those variants, H1, H2, and H3 can infect humans, but you can also see down here that H1 and H3 can infect swine. So this is where pig flu came from. It was a flu developed or that originated in pigs, but because it has a hemagglutinin that is compatible with humans, it was able to infect us. And then there's equine versions, which are H3 and H7, where H3 would be the only one that would infect humans fairly well. And then avian, all of the hemagglutinins can infect birds, and that's because it is originally a bird virus. Neuraminidase, so this is used again for viral exit. And there are 9 variants. The 2 that are primarily infectious to humans are N1 and N2. However, swine have very similar neuraminases, so N1 and N2, equine N7, N9, and avian all. So you guys should probably remember hearing about bird flu, which was H5N1. So H5 would only technically infect avians, but it had the ability of crossing over into humans. And when it crossed over to humans, it was pretty deadly. It's pretty toxic. But the good thing is because it was H3, it was self-limiting in that person that was infected. So if I were to come in contact with an infected bird with H5N1, I would get the virus, I would get sick, and I would die, but I wouldn't be able to transfer it to another unsuspecting human because it doesn't have the H1, H2, or H3 variant of hemagglutinin. My computer is taking forever to transition to slides for whatever reason. Hopefully it does it. Okay, I don't know what that was about. So treatment for influenza. So amantadine, this blocks replication. Relenza and Tamiflu block neuraminidase. And vaccination is by far the most widely used, at least in the United States. Amantadine and Relenza, and Tamiflu don't work very well, so they're generally only reserved for people who severely need them to prevent any more resistance forming from the viral mutations. Vaccination, so there's an inactivated vaccine, which is the most common in the United States, and this is basically an injection, and then the attenuated vaccine, which is flu mist, which is a nasal spray, tends to give you better protection. However, the problem with this is there's a good chance you'll get the flu after getting the vaccine. And new trivalent vaccines each season. And the primary reason for this is because of the antigenic drift. So this is the mutations that are occurring on a constant basis. These are just normal, generally point mutations occurring in the viral genome. And these mutations result in them modifying their external proteins, primarily hemagglutinin and neuraminidase, preventing antibodies from functioning, or the antibodies your body produces from one infection functioning for the new mutated version of the infection. So for that reason, we have to create new vaccines each year. The good news is that influenza mutates in a fairly standard, reproducible way, so we can kind of predict what kind of mutations are going to occur. And that's how we can produce vaccines, 6 months in the future. don't know why this is taking so long. Okay. So flu over the years, I think the biggest take-home message from this is that there have been periods, especially here and here, where H1N1, which is generally considered pig flu, at least recently, has killed many, many people. So killed about 50 million people worldwide in 1918. So it was a pretty severe pandemic. And it was primarily caused by World War II. Because World War II resulted in many different countries coming together, fighting together, living in pretty nasty conditions, and then they would go home after the war and spread it to their families. So it was pretty nasty stuff, but you also have to remember that this was before the advent of antivirals, before the advent of vaccines. So it's definitely scary, but I wouldn't expect that anytime in the near future. But you can see as we go on, there have been other cases of where there have been large flu epidemics that have resulted in a lot of deaths. But again, most of these deaths, at least in most recent times, are in the extremely old, the extremely young, people who have weakened immune systems. However, there is a possibility for this H5N1 bird flu to become a pretty serious pandemic if it has the ability of transferring from human to human. If that ever happened, it would become a very, very serious disease that would need worldwide attention. Alright, so lower respiratory tract diseases. So these are diseases that affect the bronchia, bronchioles, and the lungs. So the lowest part of the respiratory tract. So as you can imagine, these would probably be one of the more severe, because this is where oxygen is directly being taken into the body. And these two common diseases that are caused by or infect the lower respiratory tract are tuberculosis and pneumonia. So tuberculosis is a Mycobacterium tuberculosis. Most humans are resistant to the disease, so only about 5 to 10% of people who are infected with tuberculosis will actively get TB infection or disease. Now, if you've come into contact with TB, but you're not in this 5 to 10%, but then you acquire HIV, you now have a new risk associated with your immune system. So your immune system is going to be weakened by the HIV, which results in greater chance of getting active TB. Untreated TB progresses slowly. It's a very, very slow growing organism, very, very fastidious. So it takes a very long time for it to really set up shop and cause significant disease. And then clinically, TB is divided into primary tuberculosis, secondary tuberculosis, and disseminated tuberculosis. And this is what you get only in this 5% of people who become actively infected. So tuberculosis, again, is Mycobacterium tuberculosis. This is what it looks like. Very slow growing organism. It has to be grown on a special chocolate agar plate, which has a lot of nutrients in it to kind of increase its growth. It's an acid-fast bacterium. That's where you should be able to know that just from mycolic acid. Transmitted via droplet transmission. You only need, I think, 8 or 10 organisms to become infected with the organism. So it's pretty easily transmissible and pretty easy to become infected with. It's not easily killed by phagocytes, and in fact it actually lives inside of phagocytes. It prevents the phagosome-lysosome fusion, so the Mycobacterium prevent being killed by this, and then they just kind of live happily inside of there. And a long course of antibiotics are needed, and this is primarily because the macrophages then become walled off by other immune cells because they're recognized as being infected, and this walling off feature acts as a penetrant or a barrier to the antibiotics. So the antibiotics it becomes very difficult for them to make their way into these walled off cells. So primary tuberculosis starts after a period of hidden infection. So this hidden infection is often called latent TB. You have no symptoms at all, so you're usually asymptomatic, or you may get a very mild fever, but generally you would never associate this with something like tuberculosis. Most people who get this 90 to 95% of the people who get this, it goes away, or the body keeps it in check enough to where you never get active TB. But in 5 to 10% of the people who become infected, they go from this stage to about this 3 to 4 week immune system mounts a cell-mediated assault, a large influx of mononuclear cells into the lungs. So essentially, you have these macrophages that are infected with the Mycobacterium tuberculosis, and then these mononuclear cells form a wall of cells surrounding them because they're too large to phagocytose. And they're too large to phagocytose because they are the largest phagocytosing cell. So there's nothing else to come around and phagocytose them, so it becomes an issue. So what the body does instead is wall them off and kind of dump nasty chemicals on top of them in hopes that these chemicals will kill the infected macrophage. And generally the infected macrophage does die, but what ends up happening is these macrophages, once they die, they kind of fuse together and form very large kind of masses of macrophages, and this acts as like a nice little barrier for the mycobacterium to grow in. Once these walled off cell macrophage barriers are formed, they're called tubercles, and frequently the centers of these tubercles break down into necrotic calcareous lesions. So as this keeps happening, because there's nothing to clear out the dead large macrophage ball along with the microbacterium, so what ends up happening is just more cells come, more cells come, more cells come, and create an even larger ball, and eventually all these chemicals just kill anything on the inside, including host tissues. But the funny thing is they don't actually kill the Mycobacterium tuberculosis. So what ends up happening is you get necrotic lesions just of dead tissue in the lung, and they end up calcifying just by calcium in the blood kind of forming over these large dead pockets of necrotic tissue. And this is what you can actually see on an X-ray in someone who has active tuberculosis. It looks like big kind of white spots in the lungs. And at this point you would be positive for the tuberculin reaction. So this is the calcareous necrosis. So you can see this kind of large blob of pink, and this large blob of pink is actually dead macrophages which are swarming with Mycobacterium tuberculosis, and then surrounding them you can see this kind of large infiltrate of mononuclear cells, and these mononuclear cells are just sitting here dumping stuff on top of the tuberculosis. And this is what eventually forms a calcareous granuloma. And then you would become positive for the tuberculin test, which is the easiest test to perform, but it's also notoriously false positive. So it's not necessarily the best test, but it does give you an idea. And generally you get an injection of PPD, which is just bits and pieces of tuberculosis, and you'll get this dermally, so directly under the epidermis, and then you wait for a reaction to occur. So the reaction is actually your T cells that are circulating throughout the body responding to the smushed up tuberculosis. And the reason they do this is because they've come into contact with it before, thanks to this granuloma, and so they know when they see it again, they know to react, and that's when you get this nice inflammatory lump, which results in a positive result. A negative result would look flat. You wouldn't see anything. So now once you get these tubercles, they can live, the bacteria can live in there and remain dormant and become reactivated weeks, months, or years later. So they kind of just live, hang out inside of this like mass of dead macrophage calcified balls and they will just sit there and wait. And for whatever reason they go into a dormant latent state. And we're not exactly sure how or why, but it's definitely a hot button topic. A lot of people are studying it. And this is when you get chronic tuberculosis. So tubercules filled with bacteria expand and drain into bronchial tubes and upper respiratory tract. And then you can get violent coughing, greenish or bloody discharge, low-grade fever, anorexia, weight loss, extreme pain, night sweats, chest pain. And this is all from just the undulant, the leftover bits and pieces of the macrophages along with some of the bacteria draining throughout the body. And what can end up happening Because of this drainage, is you can get extrapulmonary tuberculosis, and this is where you get TB outside of the lung. You'll get this a lot in immunosuppressed patients or young children who have tuberculosis, and this is where you'll get TB growing in the lymph nodes, kidneys, long bone, genital tract, brain, and meninges. And this is very severe. There's really hardly anything you can do at this point other than support the person and hope for the best. How do you diagnose tuberculosis? So I've told you about the tuberculin skin test, but it's notoriously false positive, and that's because there are many mycobacterium species, not necessarily tuberculosis, but other mycobacterium species found in the mouth, and generally there's some cross-reactivity there with your immune system. So often chest x-rays are done, and you can see here this person has this kind of wispy white looking appearance, and these are those calcified granulomas in the lung. So if you see that, then yes, you can say that they're positive with tuberculosis. However, if they're in a dormant or latent state, generally, or in an early state of tuberculosis, you won't see these very well in an x-ray. So then that's when you have to go into a acid-fast stain from sputum, but even an acid-fast stain from sputum, if there's not enough organism, you may not see anything. So it's hard to really come up with a definitive diagnosis for tuberculosis. There really isn't a perfect test for it yet. There's another type of test which isn't listed here called a quantiferon test, and this is where you actually take T cells out of blood and you culture them, and then you add in tuberculin or tuberculosis antigens, so smushed up tuberculosis, and you looked for a T cell response. So it's much more sensitive, and it has a lower false positive rate than the tuberculin skin test, but it's still not perfect. And there's also some vaccine adjuvants or vaccines, especially the tuberculosis vaccine, that can give false positives. So if you've ever either were born in a third world country or have visited a third world country, you may have already had the tuberculosis vaccine, and as soon as you get that, especially this tuberculin skin test becomes positive, and there's really no way to determine if you are actually infected. Pneumonia. So pneumonia is essentially an inflammatory condition of the lung, and it's inflammation that occurs in the alveoli, blocking off the ability for liquid to drain properly, and also you get a buildup of liquid from edema just from the inflammation in its own right. So basically your lungs fill up with fluid, preventing you from bringing in oxygen or disseminating oxygen throughout the body. Being caused by a wide variety of different microorganisms, and it can also be a secondary infection or secondary problem after having a upper respiratory tract infection that has gone untreated. Viral pneumonias are usually milder than bacterial pneumonias, which is pretty true with most viral infections. For whatever reason, well, viruses are usually self-limiting, just like they were when we talked about meningitis and encephalitis. So for that reason, they're generally less severe. There's community acquired, meaning you get it from your neighbor or someone you come into contact with. But there's also nosocomial pneumonias, which generally are only found in the immunocompromised, and they're often associated with hospitals because there's a lot more immunocompromised people in hospitals. And they begin with upper respiratory tract symptoms, including runny nose and congestion, followed by fever, and then you get an onset of lung symptoms, so chest pain, fever, cough, and discolored sputum. So this is essentially what happens. You get bacteria in the alveoli, which results in inflammation. This inflammation kind of closes off the bronchiole, preventing the fluid from leaving, and it also results in more edema, so a buildup of more fluid, and the more fluid here, as soon as fluid fills up into the lung here, there's no oxygen getting through. So you lose the ability or the capacity of bringing in oxygen. Also results in a pretty deep, kind of crackly cough, and that's this fluid kind of moving around as you cough. So Streptococcus pneumoniae is a pretty common organism, especially in nosocomial infections. It's called pneumococcus when it causes pneumonia. We've talked about Streptococcus pneumoniae before for causing meningitis. So generally it would cause something similar to pneumonia first, and then it would migrate into the blood, followed by the meninges after passing the blood-brain barrier. Capsules is its main virulence factor, so prevents phagocytosis, and there is a vaccine available. You can see here that it's an alpha hemolytic streptococcus because it's got this nice green color associated with it. Legionella pneumophilia, also known as Legionnaire's disease. So it was first described in 1976 in Philadelphia. It's called Legionnaire's disease because the disease actually broke out in a meeting of legionnaires. So legionnaires is kind of an old school term for like a diplomat, I guess, in the area. And basically it was found in the water supplies, primarily found in the AC ducts at the conference in Philadelphia. So these AC ducts tend to form a lot of condensation, so buildup of water, and this water can sit for prolonged periods of time. As it sits for prolonged periods of time, you get amoeba growth. So amoebas are just, eukaryotic cells found in the environment that are almost ubiquitous in water, and occasionally you'll get Legionella bacteria growing inside of these amoebas. And then what ends up happening is the Legionella bacteria takes over the amoeba for all intents and purposes, and then starts to bud off of the amoeba. And as it buds off, it becomes aerosolized, and if it's in the AC duct, these aerosols can then be spread throughout the air conditioning system, resulting in this pneumonia. It's an intracellular parasite of phagocytes once it gets into a human, and it is a very serious pneumonia with about a 70 to 80% fatality rate or mortality rate. And it actually resulted in a large revamp of all heating and cooling systems, especially in high sensitive areas like hospitals. So we've developed ways to prevent this from happening, and that's why you rarely hear of Legionella anymore. Mycoplasma pneumoniae, so this is the most common version of walking pneumonia. So walking pneumonia means it's a pneumonia that generally feels like the flu. It doesn't really turn out to be terribly serious. Not terribly serious, and it's called walking because you can basically walk around and be fine with it. Generally just causes kind of a deep, wispy, kind of crackly cough, but as long as you have a competent immune system, you should be okay. It should kind of go away on its own. And these Mycoplasma are very, 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 very small bacteria, the smallest that we know of, and they have no cell walls, and cells are very variable in shape. Alright, so now on to Hantavirus. So Hantavirus is another severe pneumonia type illness. It has an even more severe hemorrhaging side effect if you have the infection for a prolonged period of time. Developed discovered in the 70s, but we didn't really care too much about it until it made its way to the US. And it had a big outbreak in 1993 in the southwest Four Corners region. So Four Corner region, I think, is like Arizona, Colorado, Utah, and the other square-looking one. Can't remember. New Mexico. But essentially, it's a very desert, dry region. And the reservoir for this virus is the deer mice. So what ends up happening is it passes through the deer mice and is excreted by its feces or urine. And this will dry out, and then the virus just sits there in a desiccated form and can be active for years. So as soon as you disturb the feces or disturb the urine, the dried urine, it becomes aerosolized. You can breathe it in, and then become infected with the virus. It results in a cytokine storm, and occasionally, like I mentioned before, hemorrhaging. But it has a pretty high fatality rate of about 40%, which is pretty severe. And there really are no known treatments other than supportive care. So you just keep the person's lungs from filling up with fluid, try to prevent dehydration, and then cross your fingers and hope for the best. It's sporadic, and it's primarily due to change in seasons. That's why you see it in the desert region. So this May 1993 outbreak was actually caused by a spring cleaning epidemic. So you had a very dry, winter, for whatever reason, probably because it's a desert, and this dry winter allowed or didn't wash away the feces and the urine from the mice that were infected. And then when spring cleaning came around, people were sweeping and blowing up the dust, and many people became infected. Histoplasmosis, so Histoplasma capsulatum, it's a dimorphic fungus, meaning that at room temperature it's a mold, and at 37 degrees or body temperature it becomes a yeast or single-celled mold. It has worldwide distribution, but it's very common in the Ohio River Valley, so it is pretty common in Ohio. But only about 1% of the people who come into contact with it become infected. But when they do become infected, it's a pretty serious lung disease. It pretty much can cause some pretty serious pneumonia-like illnesses. The 1% who become infected aren't necessarily immunocompromised, although they're the vast majority of the population. But it can also be people who have just an immune system that does not recognize the Histoplasma capsulatum. It's generally found in soil, so if you're scared of it, don't go digging around in soil. Then lastly, Pneumocystis carinii or Javarkii. So carinii is the old school name, Javarkii is by far the more common, so it's called PJP for short. So because the pneumocystic Javarkii pneumonia, so that's where the PJP comes from. So it's most common opportunistic disease in AIDS patients. So this is usually what kills a person who has AIDS. It's very, very common in the later stages of the HIV infection. So it produces inflammation in the lungs. So traditional antifungal meds are ineffective, and tryptamine sulfamoxin is used. This is actually a antihelminthic agent, so it works, not very well, but you would only see this in someone who is immunocompromised, severely immunocompromised, such as an AIDS patient. Otherwise, it's just unheard of. And here's just a nice little